Uh, that's a short CV of Dr. Aizati. So today we will talk about the pharmacogenomics, and it's a really very advanced topic currently since the completion of Human Genome Project about almost 2 decades ago. This field, as the backbone of personalized medicine or precision medicine, has been developing very fast. And pharmacogenetics already helps to advance many fields in medicine, such as cancer, psychiatrics, internal medicine, etc. And one field in which pharmacogenetics can also contribute to improve the medical healthcare is in the field of obstetrics or pregnancy. However, as far as I know, maybe Aizati can correct me later, the research about the role of pharmacogenetics in this field is still in its infancy. Sorry, it's still very limited, and only a few researchers working on this field. And among the few is Dr. Aizati. So we are very lucky to have her here to share her knowledge about this topic. So without further ado, with all respects, Dr. Aizati, please have your time.
Okay, Assalamualaikum. Can I have a audio check whether you can hear me properly?
Yeah, yes, clear.
Okay,
Clear.
okay. Thank you very much. First of all, thank you very much to Dr. Akbar, and also for the kind introduction, and also the Dean of Pharmacy, Fakultas Farmasi Unhas. And I would like to also say thank you for the invitation for this webinar. And I'm honored to be here to share some of my experience and some thoughts in this topic. And I noticed your background, Akbar, is the University of Groningen picture.
Remain the old days.
Yeah. So we both are doing PhD in the same university, me and Akbar. I will continue with sharing my slides. Can you see that, Akbar?
Yes, clear.
Okay. All right. Okay. Today I will be sharing a bit about pharmacogenomics in obstetrics pharmacy. So it's a mouthful, and the topic might be a little bit technical to those who are not in this field, but I will try to explain in a more general way. Okay. And we'll be talking more about the challenges and opportunities, because Akbar mentioned before that it's still in its infancy. So maybe we can also share our thoughts, and also I would like to hear your feedback as well and comment as well. So a little bit about the introduction of precision medicine. What is it? Okay, it's also called personalized medicine, so it can be used interchangeably. So traditionally, we prescribe medication using a standard dose to all patients, and it's based on the dose range from clinical trials. Okay, in the clinical trials, we have selected of patients in which we test for the toxicity dose and for the dose that is effective for that medication, and we'll be using that standard dose for everyone. But then it turns out that this particular dose might not work for some patients. So some patients might have a high risk to get side effects with this dose, and some patients, for some patients, it's not even effective. So that means the patients need more of that dose, whereas some proportion of patients um, can benefit with that dose. So that means there is another predictor that might predict, okay, whether this patient is going to benefit from that dose, or he or she needs a different set of dose. So this is when we look at the effects of the genetics. Okay, so from the pharmacogenetic study, we can actually stratify the patients according to their genetic pharmacogenetic profile, in which later on we translate into their needs of a change of a dose, or whether they need a standard dose or lower dose or higher dose. So we'll be discussing more about it later. So what does it mean by pharmacogenetics and or pharmacogenomics? Because you might heard I use it interchangeably as well, pharmacogenetics and pharmacogenomics. So pharmacogenetics is a study of variations of DNA and RNA characteristics as related to drug response. So anything related to pharmaco, which is pharmaco is the drug, and genetic is the genetic. So anything related to the association between genetic information and the response to the drug. Okay, so it can be the treatment outcome and also the risk to side effects. Whereas in pharmacogenomics, it's a broader term in which it is a branch of science concerned with identification of genetic attributes of an individual that leads to variable responses to drugs. So it's actually overlapping, and it can be used interchangeably as well. So when we talk about pharmacogenetics, maybe not all of you are familiar with the basic of pharmacogenetic approach. So we actually identify genetic variants or genetic variations in the patient's genetic information, and we relate that to the pharmacokinetics and pharmacodynamics of the drug. So one of the most common type of genetic variation that we see or we're going to look for is the SNP. So this is the first one, a single nucleotide polymorphism, or we call it SNP. So what is SNP actually? SNP is a change of single nucleotide at one particular location in the genome. For example, if you look at this picture, so we have the first strand here with C in this location. And for those who have the SNP, so in the same location, instead of C, they have T. So there is a change in the particular nucleotide. And for example, we have 100 population, 98 had C nucleotide in this position, whereas 2 of the people have T genotype, T nucleotide. So those 2 people had the SNP. And in order for it to be called a polymorphism is when the change is actually 1% or more of the population. So SNP is actually very common. So it can occur every 100 to 300 bases along the 3 billion base of human genome. So it's very common. So one person can have 10 to 30 million SNPs. But we should not be alarmed because not all of these SNPs are actually functional or can cause clinical relevance. So it depends on the functionality of that SNPs. So we are only interested in the SNPs that are having or causing a change in amino acid produced. Because if you know the basic genetics from this genetic profile, it will, the nucleotide will be transcribed and translated into amino acid, and this amino acid will subsequently be forming proteins. So if there is any change in this in the nucleotide base, so it will cause change in the type of amino acid produced. So there will be a different protein produced, or there is a higher or lower expression of that protein. So this is what the change that we are looking for. So when we want to bridge between genetics and the drug, so as a pharmacist, we have to know about pharmacokinetics and pharmacodynamics of the drug. So now looking at the genetic variation, we actually can identify what are the genes related to pharmacokinetic of that drug. And we can actually pinpoint, okay, what type of variations that happen in that genes and what are the cause it made to the absorption, distribution, metabolism, or excretion. So the most common example in the pharmacogenetics of pharmacokinetics is the involvement of drug transporter proteins, which involve in the absorption, and also metabolism, which involve the cytochrome P450. So mainly the pharmacogenetic predictors are actually based on the cytochrome P450 metabolism. Where else in pharmacodynamics, we identify genes that are related to the pharmacodynamic of that disease. So in this case, we identify genes that might potentially affect the response of the medication, of the treatment. So it can also be involving drug transporter proteins or receptor, because drug will act to that receptor. So if there is any change in the expression of the receptor, so there will also be change in the response of the drug. So coming to the implementation-wise of pharmacogenomics, how far is it being implemented? So there's already a lot of guidelines on recommending the change of dose for certain drugs that are implicated by the change of pharmacokinetic change based on cytochrome P450 mainly. So CPIC is the Clinical Pharmacogenetic Implementation Consortium. So they are the ones who have been releasing a lot of guidelines of dosage adjustment for certain drugs that are implicated by the allele or the pharmacokinetic alleles. So for example here, if you look at the phenotype here of drug metabolizing enzymes, we have ultra-rapid metabolizers, rapid metabolizers, normal, intermediate, and poor metabolizers. So the group that we are concerned more are those who have ultra-rapid metabolizers and poor metabolizers, in which we expect that there will be a change in their rate of metabolism of the drug. And we also need to look at the specific drug that we're going to look at, which cytochrome P450 are responsible for the metabolism. Okay. You can just disturb me at any time if you're not clear with anything that I mentioned. Otherwise, you can wait until the Q&A and ask. I hope it's clear on this part. So now coming on to the obstetric pharmacy part. So why is it important for us as a pharmacist to know? So if any one of you have heard about thalidomide tragedy, it actually happened in 1960s. So there is a lot of use of thalidomide as an OTC medication, because it's very effective in reducing emesis, or nausea and vomiting during pregnancy. So a lot of pregnant women are using thalidomide when they are pregnant. So it can be it's available in pharmacies, and they can just buy it. But then suddenly a few years later, there is an ONG specialist. He noticed that there is a sudden surge of babies that are being born with congenital anomalies. So this condition is called Kembali. So there is a disruption in the formation of limbs, and he noted this condition, and he published in Nature, and then he asked his fellow practitioners whether they are also seeing this kind of trend. And it seems like all of them are actually noticing that. So it turns out that they trace what are the things, the different things that these mothers are taking when they are pregnant, and it turns out it's caused by thalidomide. So it's taught us that whatever it is that the mother is taking, there is a possibility that that thing or that drug or that external thing that mother is taking is going to pass through the placenta and harm the fetus. And another thing to that we can learn from thalidomide tragedy is that um, the effect of the drug in animal studies might not be the same with the human studies, because thalidomide has been tested in animals before, but it didn't have this kind of effect. So from this tragedy, there has been a revised of guidelines on and a revised in guideline and enforcement in limiting the drug use in pregnancy. So we are being more vigilant in what we give to pregnant women. So there is quite an important role of pharmacists actually in obstetric pharmacy, because we are the one who should know about the medication, and pregnant women sometimes they need to take medication, although some of them might not want to use it for like nausea or vomiting or headache. They can just bear with it. But then some women, they need a continuous medication, for example, for chronic diseases, and it's inevitable for them. Otherwise, the pregnancy itself will also be threatened by the disease condition. So it's creating a lot of concern to them. So it's our role as a pharmacist to actually convey this information for them, and providing the best medication or therapy management during pregnancy. So some of the role of pharmacists here is the drug therapy management in pregnancy in these conditions. For example, gestational diabetes, preeclampsia, and next pharmacokinetic based treatment, TDM, for example, of this selected medication, anticoagulant dosing, heparin and warfarin, because pregnancy condition itself might promote thrombosis. So this might affect the effect of the drug itself. The treatment of HIV positive mothers and their offspring, how the use of HIV medication might prevent the fetus from getting HIV. Maternal fetal medicine, the management of chronic diseases during pregnancy, the one that I mentioned before, the chronic diseases like epilepsy, depression, or asthma, and drug counseling in pregnancy and lactation. And also our role as a pharmacist to provide that drug information on the safe use of medication during pregnancy to the patient themselves and also to the healthcare providers. So previously, pharmacists are the one being recognized as those sitting at the counter or behind the counter, and then next we move to the direct patient care in clinical pharmacy. And I believe in the future, pharmacists can also be the gatekeeper of information. With the advancement of technology in genetics, we are the one who should be in the front line in giving the accurate information on how to actually facilitate with the precision medicine. So we are the one who should be responsible for this. So areas of pharmacogenetics research in obstetric pharmacy. So I will be touching a little bit about some of the diseases or some of the condition in which pharmacogenetic studies have been done. So it might not be covering all, but at least some examples. So I start with pharmacogenetics in antidepressants use in pregnancy. So this is under the psychiatric disorders. So this is the topic 4. And depression occurs in 3.9 to 12.8% of pregnancies. And SSRIs, the selective serotonin reuptake inhibitors, are the most recommended therapy during pregnancy, and the percentage of pregnant women using it between 1.2 to 6.2. It's actually one of the safest antidepressant to be used during pregnancy as compared to the older generation of antidepressant. And when we want to do a pharmacogenetic study, we have to look at the metabolic enzymes in which metabolizing our medication, our drug. For example, here we look at the CYP2D6. It metabolizes paroxetine, fluoxetine, duloxetine, and venlafaxine, while CYP2C19 deactivates citalopram and escitalopram. So this drug, might be metabolized by more than one metabolic enzyme, but we chose the one that is the main metabolizer for that drug. And to make it more complicated, the pregnancy itself might also cause a change in the activity of these enzymes. And there is a report saying that there is a higher metabolism of most of the SSRIs during late pregnancy because of the increase in activity of certain metabolic enzymes in the later stage of pregnancy. So it cause a lower maternal level of these SSRIs. Therefore, it might lead to decreased efficacy or effectiveness of that medication. So in a pharmacogenetics approach, we look at the polymorphisms of these enzymes, and it can change the metabolic rate clearance and also subsequently change the level of this drug. For example, I mentioned before the poor metabolizers, the PM of CYP2D6, it will metabolize paroxetine slower. Therefore, it might cause accumulation and increase in paroxetine level as available in maternal circulation. In mothers with intermediate metabolizers or poor metabolizers, CYP2D6 genotype showed an increase in plasma concentration of paroxetine of 0.82 milligram per liter for each week over the course of pregnancy. So there is a significant change in serum level actually. So it will then increase the amount of paroxetine that might pass through the placenta and affecting the fetus. So this is my topic that I've been working before. The SSRIs induce congenital heart anomalies. So congenital heart anomaly is a type of birth defect which affecting the heart. So SSRIs has been used widely before during pregnancy, but then in 2005, US FDA have issued a warning on the risk of on the increased risk of congenital heart anomaly cases among babies in which the mother had used SSRIs during pregnancy. But following on that, there's been a lot of case control studies based on retrospective data, and pharmacovigilance studies have been done, and there has been an inconsistent result actually in assessing the association whether SSRI use is really going to increase the risk of heart defect. And so far, paroxetine has been the one that is causing more risk as compared to other selection of SSRIs. So currently, sertraline is the one that is being recommended to be used for depression in pregnancy. And in this study, we identified there are several genes that might potentially play a role in the risk of heart defect among babies exposed to SSRIs during the first trimester. So it can involve serotonin transporter proteins. So this gene, SLC6A4, is encoding for serotonin transporter proteins, as well as the serotonin receptors. So these three genes are encoding for serotonin receptors. But however, unfortunately, in our study, there is a limited sample size. Therefore, we cannot establish statistical significance. But it can be treated as the indication that there might be something some role of these genes play in the risk of heart defect among babies who are exposed to SSRIs, and it warrants further study. So that's about the psychiatric disorder, the antidepressants in pregnancy. Next is the gestational diabetes. So a lot of these studies on gestational diabetes are actually as an extension to pharmacogenetic predictors of type 2 diabetes. And the prevalence of GDM has been reported between 7 to 18 of pregnancy worldwide. So it's quite common. Whereas in Malaysia, 8 to 9% of pregnant women in Malaysia had a GDM. But this is quite a while ago, so maybe it increased or maybe it decreased now. I'm not sure. So candidate gene studies and GWAS have also identified genetic markers associated with maternal metabolic traits, and most of which are similarly associated with type 2 diabetes. So they found some predictors that might be related to the pharmacodynamics or pathophysiology of type 2 diabetes. And it also applies to patients with gestational diabetes too. So candidate gene, for those of you who are not familiar with this, candidate gene analysis is when we study each gene and what is the effect on the treatment outcome or the risk of getting a disease. It's only a single gene study. Whereas in GWAS, which is the Genome-Wide Association Studies, this is when we have a lot of samples and we divide into cases who had that disease. For example, in this case, GDM. So we have a group of cases of GDM and a group of control without GDM. And then we use a whole genome sequencing. So we sequence all the genetic information, and then we compare between these two groups. And if we get the hit of the SNPs, there will be a lot of other post analysis after that, bioinformatic analysis after that, and we come up with several lists of genes that might potentially be significantly associated with that disease as compared to those who do not have that disease. And also these two genes are uniquely associated with maternal metabolic traits in GDM. So next is the gestational hypertension and preeclampsia. For preeclampsia or gestational hypertension, there is a large subgroup of pregnant women with preeclampsia is non-responsive to antihypertensive drugs. For example, metidopa, nifedipine, and hydralazine. And these pharmacogenetic studies were targeting the SNP that related to the nitric oxide production, oxidative stress, and endothelial dysfunction. So these are the genes that might be related to the build-up of the oxidative stress and endothelial dysfunction, because these are the proposed mechanism of preeclampsia and gestational hypertension. So they're looking at the pharmacodynamic parameters. Whereas there's also a role of gene-gene interaction between several genes that might be associated with PE, and also the response to antihypertensive. So currently the treatment wise is we give all of them the same. It's either one of these. But then we found out that some of them are not being responsive to this medication. Only then we identify what are the problem or what are the things that we can improve from that. So that's including the genetics part, epigenetics and genomics part. And then only then we continue with individualized therapy and monitoring. So another area is the drug use in breastfeeding or lactation. So this is the issue of the use of codeine during breastfeeding. So in 2015, FDA has recommended against the use of codeine in women who are breastfeeding because of the effect of genetic predictors. So mothers who have ultra rapid metabolizer of CYP2D6 and taking codeine during breastfeeding. So there is a rapid conversion of codeine to morphine. So there is a surge of morphine in a short period of time, and with this level in the maternal circulation, um, it will be transferred into the breast milk. So if the woman is breastfeeding the baby, so the baby might consume the milk that contain morphine in it. So there is a risk of respiratory depression in breastfed infants when the mother is using codeine and the mother had ultra rapid metabolizer. So this is why FDA has restricted the use of this anesthesia, the codeine, during lactation. Sorry. So that's a little bit about what had been done. So it's not all. There's still a lot more, but at least you get an idea how we go about this pharmacogenetics research in this area. So moving on to the pharmacogenetics research in Malaysia, this is some of the institutions that have been doing pharmacogenetics research. And again, it might not be all, but this is what I can put now. UITM, they have the Integrative Pharmacogenomics Institute, I promised. UMBI is attached to UKM, University Kebangsaan Malaysia. And we also have the Ministry of Health, IMR, Institute for Medical Research Malaysia. And we ourselves, USM, we are among the team that are doing pharmacogenetics research, and also UM. And some of the prominent areas are the HLA genotype and the risk of drug hypersensitivity, because HLA genotype is actually one of the a success story in pharmacogenetics, actually, because in Asian population, one specific marker, which is HLA-B 1502, has been significantly associated with an increased risk of Stevens-Johnson syndrome among patients who had this kind of marker as compared to other people. And this marker is actually more prominent in Asian population as compared to European or Caucasian. So this is one of the most important area in pharmacogenomics. And also population genetics in Southeast Asia, Malay, integration between pharmacogenomics and my pharmacometabolomics in clopidogrel therapy. So this is from our team in USM, and we're also continuing with clozapine now, and also pharmacogenomics of cancer therapy. So moving on to the challenges. There's a lot of challenges in pharmacogenomics research, especially for candidate gene and association study, because there is a limited utility to identify genes that are associated with complex diseases. So I will explain later about the polygenetic risk score for complex diseases. For candidate gene analysis might not be able to explain the whole scenario of complex disease. And there's also a lack of large population data sets, in which studies were done in small scale and small number of samples. There's also population heterogeneity. I think it's relevant for both of our countries, because we have a mix of population. And usually in Malaysia, if we do a pharmacogenetic study, we will separate Malay, Indian, and Chinese as a separate population. And that might also limit the number of samples some more. And also there is a lack of replication of findings. One finding cannot be replicated with the next. And also the presence of gene-gene interaction. I mentioned it before. Maybe Akbar is more knowledgeable in terms of gene-gene interaction, because he's been doing that type of study before. A complex interplay with environmental exposures and other external factors. in which we cannot really control about medication adherence, drug interaction. We can only take note of that parameters and maybe put it up in the model for the prediction. So yeah, the highlight here is in obstetric pharmacy. There are additional challenges actually if we want to do this in this area, because we are looking at the fetal exposure to drugs in utero, in which it involves a complex pathway between maternal factors, the placenta layer, and also the fetal factors. And we have to take into account all the alterations in maternal pharmacokinetics during pregnancy, maternal pharmacogenomics, placental barrier, and the fetus genetics. So this is what I proposed before with my team, is how the maternal factors are being taken into account, in which we have to take into account the physiological changes during pregnancy. So there is an increase in total body water, increase in volume of distribution of the drug, and also the pharmacokinetic parameters, how pregnancy itself cause the change in expression of metabolic enzymes, and some more about the drug interaction and the genetic polymorphism of that metabolic enzymes, transporter proteins, and also the drug factor itself. And the second step is the placenta layer, because placenta is actually the barrier between mother and the fetus. So whatever it is that the mother is taking, it has to undergo placenta layer first before it reach fetal circulation. So if there is any change in the expression of drug transporter protein in the placenta layer, so there will be a change in the amount of drug that is being transferred between maternal and fetal circulation. So PGP is the main drug transporter protein in placenta layer. And next, if the drug already passed through the placenta to the fetal circulation, we have to take into account the expression level of metabolic enzyme in the fetus. When is it, in which gestational age that this metabolic enzyme is going to be functional or not. So we have to take into account all these parameters and predictors. So these are the the drug transporter proteins in the placenta layer, in which we have stratified into the phenotype grouping. So opportunities. Oh, it's already 10:43. I will move faster. So there are a lot of opportunities in pharmacogenomics research in obstetric pharmacy. The first, we need to incorporate other potential biomarkers like epigenetics, metabolomics, proteomics, and transcriptomics to make it as whole as possible in the determination of the risk or the stratification of patient, whether they're going to be responding to that medication, or they're going to have a side effect for that medication or not. So these are the other biomarkers that we need to incorporate as well. The second is polygenic risk scoring. This is more on the complex diseases, in which each markers will be given a point, and they will be weighted, and they will have a list of markers that will make the scoring, in which we can use that polygenic risk scoring from other population, and we test it in our population to see the clinical utility, and then we move from there. So it's not necessarily we start from the scratch. We can also adopt from other population and then test it in our population. The third is data source from direct to consumer genetic testing. So if you notice, there's some companies are offering genetic testing directly to the consumer without undergoing the healthcare providers. And it's quite controversial, in which one of the company have been sued because they give the data to insurance company and the pharmaceutical company. But for me, I think we can use this we can leverage this technology actually um, to get access to the data source, provided that this service is regulated. So we need to regulate on the data interpretation and data protection and safety, and then we can use that information as a source for research. So future direction, we need to establish clinical utility in our of reported genetic markers in our population, and pharmacists can also develop a screening tool for the patient as a predictive measures to see whether the patient is going to have to benefit from that medication or otherwise. And we need to have a data sharing, more collaborations between the institutions. And there is also still a major effort to educate healthcare professionals and also general public about precision medicine, personalized medicine. So this is some of the summaries. Pharmacists might play an important role in pharmacotherapy during pregnancy, and we need to take into account maternal and fetal risk factors in terms of the genetic profile, and also can use the polygenic effect of, and also by other biomarkers in complex diseases. So these are the acknowledgement. Thank you to USM, and this is USM Pharmacare Research Group is the research group of clinical pharmacy department in our school, and University of Groningen is where I get where I did my PhD, and I get all the data there. And Precision Medicine Research Group is the new group that we are establishing now. It involves only the studies related to pharmacogenomics, metabolomics, epigenetics, and pharmacometrics. So with that, thank you very much, and we open for question and answers.
Thank you very much, Dr. Aizati, for a very interesting talk. Now we are arriving on Q&A session, so we will have some time for that. So the practical things is you can ask directly to Dr. Aizati, or if you want, you can write directly on chatting room, so I can help to read the questions to Dr. Aizati. And you can ask either in English or in Bahasa Indonesia. Is that okay, Aizati? Or
yes,
Bahasa Indonesia, yeah, you can ask in Bahasa Indonesia.
Or Bahasa Indonesia also can.
Yeah. So please, if you have some questions. So I will start by myself. So you explain about the risk of congenital anomaly in the use of SSRI for pregnancy women. And then there are some gene candidates for that, for example, related to the CYP 450 and to serotonin receptor and transporter and PGP transporter, and probably also involve the gene in which responsible for production of serotonin. And my question is, it's more about the practical things. How do you forecast the practical applicability of pharmacogenetics in this field in the future?
Oh, that's very hard question. Do you mean how to implement this kind of
yeah. How do
how
you
to
forecast
use?
that? Yeah, because now we have a DNA passport, and it's quite condensed information already there. So I can imagine if we put more genes there, it will be very, very complex things, and it will be not easy for pharmacists to use that to help the patients.
Well, first of all, with regards to the use of with regard to SSRIs and pregnancy and the risk of to the fetus, actually, there's still a lot more to be explored and to be done actually, because we need to take into account the maternal factors and the fetal factors, and also because the placenta is made out of the fetal DNA, so some of the fetal DNA is there, so that makes it more complicated of how we are going to differentiate between the maternal and the fetal genetic. But as for the in general, maybe we go one step at a time. So we establish the list of markers in our population. And I mentioned before, we do not need to do it all over again. We just take the one that is already being established in other population, and then we test it in our population, and then we go from there. So we maybe we might need to add some more, or maybe we disregard those the markers that is not relevant to our population, and then we put it as one risk score or panel. And then we also need to take into account the metabolomics, the epigenetics parameters as well. So I think we are still in the beginning or the initial period of pharmacogenetics research. It's not that much on the implementation yet. But I think for those markers that are very significantly associated with certain disease or certain risk, for example HLA, we can actually immediately do something on that. So we can already do a preemptive screening for those who needs to take anti-epileptic, and whether they are going to have adverse reaction to that medication if they have certain genes or not. So that really depends on the type of disease, and how big is the magnitude of the association. I think there's still a
Thank
lot
you.
more to explore.
Yeah, thank you for the answer. So we have one participant who would like to ask. Nana, please have your time. Unmute, please. Unmute. I
Okay.
cannot
Okay.
hear.
Thank you. Thank you for the opportunity. The presentation is really interesting for me because I have known many people who are in pregnancy right now. So my concern is the usage of herbal medicine during pregnancy. So is it possible to include herbal medicine in this pharmacogenomic and pharmacometabolomic research in pregnancy? I am wondering if it's possible to use to detect some disease marker for during pregnancy that affected by affected by herbal medicine. For example, like the gene expression of HLA cause increase of the gene because due to herbal medicine consume. Sorry, mungkin saya bertanya dalam bahasa Indonesia aja ya.
Boleh.
Bingung, sorry.
Boleh.
Saya penasaran apa bisa nggak kita menggunakan herbal medicine di sini, gitu. Yang pertama karena orang Indonesia itu mengonsumsi obat tradisional itu sangat sering gitu. Bahkan dalam beberapa kasus saya banyak dapat pertanyaan, bilang ini saya enggak, bukan hanya untuk obat OTC tapi ke herbal medicine gitu. Karena bukan hanya dari personalnya, tapi misalnya dia dengar dari ibunya gitu, atau misalnya keluarganya atau teman bilang, wah minum ini bagus gitu. Nah sekalinya mereka minum daily, habis itu ketika mereka sudah hamil kan berhenti gitu. Maksudnya bingung apa saya harus minum lagi atau tidak. Maka masalahnya kalau data mengenai herbal medicine itu sangat kurang. Untuk efek dari herbal medicine terhadap kehamilan itu masih sangat kurang gitu. Untuk data obat-obat sintetik saja ketika saya mencari itu masih agak kurang. Misalnya dia masuk di kelas A, B, C, D itu masih agak kurang. Nah ini yang saya sangat penasaran, apakah kedepannya kita bisa nggak memberikan maksudnya menambah penelitian tentang ini, atau misalnya dibalik gitu, kalau misalnya ada herbal medicine misalnya paling enggak senyawanya A, saya tes di misalnya sel, habis itu kita melihat ekspresi gennya. Menurut Ibu, apa bisa tidak kalau misalnya kita melakukan penelitian seperti itu? Gitu. Terima kasih.
Terima kasih Nana for that question. I think it's a very relevant question for our population, both of our countries, because in Malaysia we also have quite a prevalent use of herbal medicine, and during pregnancy as well. But the problem, it's not the problem, the challenge actually, if you want to identify the pharmacogenetics markers related to herbal medicine, the big challenge is that herbal medicine products or herbal medicine preparations are not standardized in terms of the dose. So because I mentioned earlier in the beginning that it's actually because of the we identify the needs for pharmacogenetic, we look at the genetic variables, because using a standard dose, some people might respond differently. But now there is no standard dose in the beginning for herbal supplements. And that makes it quite different, unless there is quite challenging, unless there is already a preparation with a standardized active ingredient of that herbal preparation. It is possible actually if all of them are using the same dose, and then we can look at the genetic predictors as well, and we can it's quite challenging as well, because not some women might also use more than one type of herbal preparation as well, so that might seem to that makes it complicated, in which there is also a herbal interaction, and also if they're also taking drugs, at drug herbal interaction, things like that. So my main concern is the standardization of the product itself. Maybe Akbar, you want to add something, because you know more about the interaction, right?
Actually, our Dean Dr. Subhan expertise in herbal and CYP interaction. So maybe Nana can directly ask to Dr. Subhan about that. So maybe we will proceed to the next questions. If there are still some participants who would like to share his or her thoughts, please, Dr. Yulia, have your time. Please unmute. So, how to unmute?
Okay, is it unmute now? Okay, thank you. Yeah. All right. So I have actually two questions, if you don't mind. The first one is I'd like to ask Dr. Aizati about her opinion on drug safety of anticonvulsant on pregnant women, because as we know that lots of anticonvulsant is triggering such as fetal deformation, but on the other hand, the mother will still need it for preventing epileptic episodes. So, do you think the screening of pharmacogenetics for the mothers will be very important, and they will have a huge benefit on it? And that's my first question. And my second question is about, you've mentioned before about genetic polymorphisms, and you've done it in Malaysian population. As we know that Malaysian population have like different ethnics of Asian people. So there is Chinese, Indian, and Malayan. So I would like to know, because this is interesting for me. Do you think they have a huge difference in their polymorphisms, or they have very similar polymorphism? Do you think like they could have different genetic polymorphism between these Asian ethnics? Thank you.
Okay, thank you, Yulia, for the question. It's also an important question, interesting. Regarding the first question on the anticonvulsant, right, the drug safety of anticonvulsant, we know the valproic acid the pregnancy risk factor D, if I'm not mistaken. So it's highly not recommended in pregnancy. So whenever the patient who is on a chronic dose or chronic use of valproic acid, when they want to plan for pregnancy, we suggest them to change to another option, probably a levetiracetam. So this is much safer because valproic acid might cause congenital anomalies, a facial deformation, and also syndrome. But in terms of the selection of which drug that are more recommended to be used in pregnancy, it depends on several factors. The first is whether the drug is able to pass through the placenta or not. So, for example, the valproic acid, it can pass through the placenta, so it might cause a direct effect to the fetus. And if it's not, then it probably is much safer. And the second is the dose effect, because in valproic acid, I think it's more than 700 milligram is the one in which we are more concerned about the congenital anomalies effect, whereas in the lower dose it probably safe. But for us, we suggest not to use valproic acid at all. So we better use with the newer generation like lamotrigine or levetiracetam. But I think the current one, lamotrigine, might also have some kind of increased risk as well. And also, if we want to put the pharmacogenetic factors in it, we have to identify what type of metabolic enzyme that are involved in that metabolism, or in the metabolism of that drug. If that drug is not majorly metabolized by the liver or by the cytochrome P450, so there is maybe a limited use of poor metabolizers or ultra-rapid metabolizers scoring. So it depends highly on the drug factor, because I mentioned before the diagram. So a lot of factors, the drug factor itself, whether it's going to undergo major metabolism by metabolic enzymes, whether it's go through first pass metabolism or not, and also the effect through the placenta, whether it's going to pass through the placenta or not. But mind that newer generation or newer drugs, we might not have that much information, because we cannot do clinical trials to know whether it's going to be teratogenic or not. So it's all based on retrospective. We have to have the study is actually based on the pharmacovigilance, in which post-marketing studies might take a few years after the drug has been marketed. And the second question, did I answer the first? Okay, the second question is about ethnicity. I mentioned before, we have usually we separate between Malay, Chinese, and India. And to be honest, I'm also not sure how big a difference it is between these ethnicities. Because if we see that in a more general term, is we compare Asian, Caucasian, and Native American, for example, there might be some big difference, but for certain gene, there might not be difference at all. So I think it can be that it is also possible to have certain differences, but for now, I'm not sure how big the difference is. It might be relevant, it might not be relevant. So that's why we need to have a bigger number of sample for each population, actually, just to compare. Do I can answer your question? Okay,
Yeah,
thank you.
thank you, Dr. Aizati. So we have a lot of questions actually in chatting room. So before that, there is someone who would like to ask directly from Malaysia, Muhammad Ridwan. Please have your time. Muhammad Ridwan, yes. Can you unmute your?
Can you hear me?
Yeah.
Okay. Thank you very much for giving me opportunity to ask the questions. Before that, just to introduce myself, my name is Dr. Muhammad Rizwan. I'm actually a medical doctor. I'm from University Science Malaysia as well. So I knew Dr. Aizati. Just to ask question to Dr. Aizati, for pharmacogenomics in obstetric pregnancy, in obstetric pharmacies, is there any countries that has started this approach in pregnancy? So I mean in practical in clinical practice, or is just this or is it this is under the research area only? If they started already in among the pregnant women, can I know what how they implement this, or are they screening the genetic the pharmacogenomic profiling among the pregnant women first before they start the medication, or they or what? Or just in case you have this kind of information. Thank you so much.
Okay, thank you, Rizwan, for the question. So if I may say about the stage of pharmacogenetics research in obstetric pharmacotherapy, it's still in the research phase, because there's still a lot of factors that needs to be to be uh, understood in terms of the modulation or the pathway between the drug exposure and also the risk to the fetus. But in terms of the pharmacodynamics markers, is actually the same with the general population. For example, markers for diabetes, for example, or markers for depression in terms of the pharmacodynamic part, which is the receptors, the transporter proteins, is the same between general population and pregnant women, because the genetic will not change. We can genotype them before. If they already have their genetic information before, we can use that one. Only when they are pregnant, we can it's also quite difficult to look at the genetic data of the fetus unless we do what is it again, the non-invasive perinatal testing, right, the NIPT. So it's also possible to get the genetic data from the fetus, but then it's more on the cases that are suspected to have a major anomaly or threatened pregnancies. But it is possible to get the DNA from the fetus. But yeah, it's still in the early stage and it's not being implemented yet. But if we want to implement that, I mentioned before, if we have like a genetic data of the mother, we can add in the other information as well. And as for the changes in physiological changes, for example, um, the VD, the drug VD is going to be changed. We can actually do a therapeutic drug monitoring to measure the level, and then we look back whether there are significant changes in serum level as well, and then we add that into our consideration.
Thank you. Yeah, thank you, Dr. Aizati. Do you still have some time for some questions?
Yes.
Yeah, okay. I will read one or two questions from group chat. It's from Rasmaya. So the question is there any recommendation for anti-hypertension dose adjustment based on genetic polymorphisms, especially in pregnancy, for example, for nifedipine?
For anti-hypertensive?
Yeah.
Oh, that one. Well, I didn't go into detail for antihypertensive, but in general, we can look at the guideline of CPIC guideline. I mentioned the Clinical Pharmacogenetic Implementation Consortium, CPIC guideline. They have produced a lot of guidelines involving specific drugs which might be implicated with pharmacogenetics markers. So based on that, if the woman is using that medication before and then getting pregnant, being pregnant, we can use that if they have we have their genetic profile, we can use that guideline as well, whether we need to reduce the dose or we need to increase the dose or any dose adjustment. And at the same time, look at the specific drug that we are looking for. See whether they are subject to changes in terms of the VD and whether it's metabolized by which metabolic enzymes. So generally, it's the same between the general population and pregnant women, because the genetic part will not be different. Only the additional part of the serum level might need a further investigation. We might do a serum level monitoring as well. But in terms of the specifically in pregnant women, I'm not really sure how far is being implemented. But then I think it's still in the investigation stage.
Yeah, maybe I can add a little bit information regarding that. So you can check in CPIC guideline, CPIC, or Dutch Pharmacogenetics Working Group guideline, DPWG. So you can Google and you can find the guideline there, and you can check the specific drug. For nifedipine, as long as you know, it's metabolized by CYP3A4, and CYP3A4 is not really a polymorphic. They have it has some polymorphisms, but it's not really polymorphic compared to CYP2C19, CYP2C9, or CYP2D6. So it's really hard to say whether there is a recommendation for nifedipine regarding the CYP3A4. But for metoprolol, although it's maybe should be considered the benefit and the risk in the pregnancy, for metoprolol, there is a clear recommendation for that from Dutch Pharmacogenetics Working Group. It stated that in intermediate metabolizer, you should reduce the dose 50%, and for metabolizer, you should reduce the dose 75%. So I hope it can help. For the next questions is from Bese Hardianti, Ms. Bese Hardianti. Genomic information is used to study individual responses to drugs. As we know, epigenetic could also influence gene associated disease. So do you think it could be applicable due to those diversity between one individual to another? Do you get the point, Aizati? So it's about epigenetic and the relation, and the relation with gene associated with disease.
So this is actually two things, right? Epigenetics and gene interaction.
Yeah, probably. Maybe Ms. Besek can clarify the questions, because I also don't really get the point here. So Ms. Besek,
Well,
maybe
epigenetics is a bit complex, because the genetics for pharmacogenetics is a bit easier because it doesn't change over the time. So the genetic for example, my CYP2D6 phenotype will be the same when I age 20 and when I age 60. So it would not change. Whereas in epigenetics, there is a methylation in the chromosome. So it might cause a change in the expression of the protein. So it can change over the time. So that is why it's also important to look at that area. So I mentioned that there is a complex a complex a combination of all areas related to genomics and also metabolomics, in which we need to work on it. So it's not necessarily we work on all of it. So, but at least we consider the results or the recommendation from other part of the areas, and put it together before and consider all of the factors or markers before we come up with one recommendation or tools or scoring, for example. I think it's a long way to go before that, but yeah, I think it's a good thing to highlight that the epigenetics and also gene interaction. Maybe you want to add in for the gene interaction, how
Yeah,
yeah.
yeah, it will need another webinar for that.
Just
So
let me know when is it.
yeah. So maybe the last question is from me, Aizati. So if you don't mind, I'm just wondering because you explained about polygenetic risk score in your several slides. What is your opinion of the use of genetic risk score in fetus screening?
Sorry, in what?
In fetus screening.
Fetus screening.
Yeah.
Oh, okay. I get your point. This is when we want to look. We want to predict whether the baby is going to have chronic diseases or not, right?
Yeah, maybe or intelligentsia, or maybe another trait.
Intelligence, yeah. There is quite a debate about the use of genetic testing to identify or predict our baby, and then do the genetic modification for that. But for me, it's fair to do that kind of testing if we have an indication that that baby or that fetus might have an increased risk to have like a major anomalies. Of course, we can do that kind of testing to see whether they have chromosomal anomalies and whatnot. But for cosmetic reasons, or if we want to predict um, their we want to predict the risk to get that chronic diseases, I'm not sure how accurate it will be if we do that, because it's still in the because even the polygenic risk score for chronic diseases is not really established, right? The genetic risk score is not really established yet, so there will always some new information to be considered, and we have to take into account whether that information is going to be useful for that baby, for that fetus or not. We might detect something, but then it might probably not affect in the real life. So yeah, it's also open for debate.
Yeah,
How
thank you.
sure are we that the information is going to be useful?
Yeah, because from polygenetic risk score we can choose whether we would like to have baby with pointed nose or handsome face or etc.
Yeah.
There's a lot of debate about that. So
Yes, but then
okay,
yeah.
yeah. Do you have closing remarks, Aizati?
I think there's one question or not.
You want to
Recommendation.
still have time for that? So if you want, I can
Yeah,
read
for the
that.
last question.
Okay. There is the questions from still from Rasmayana. Said, do you measure protein expression due to genetic polymorphisms in anti-hypertension in obstetric patients? Do we need to really measure the protein expressions or checking the genetic polymorphisms?
About the protein expression. Actually, when I want to uh, identify which SNP that might possibly affect my drug, for example, I do take into account the protein expression profile of that SNP, whether the genetic variation might cause a change in protein expression. And also some papers, they do the effect on mRNA expression, whether this SNP is going to be translated into a change in mRNA or protein expression or not, because that's also important to see whether that gene is actually encoding what we expect them. But then I think I've read before that the protein expression profile might not necessarily translate into clinical outcome as well. So yeah, because in the end we're going to use it in the clinical practice. So protein expression can also be taken into consideration, but then in the end it's actually the clinical outcome, which is the population study is the one that is going to be considered. Okay.
Yeah, genotyping doesn't always really describe the phenotype of the patients.
Yeah.
Okay, do you have closing remarks before I close the webinar?
Well, I just want to say thank you for the opportunity and the invitation. I think I had fun sharing with you guys. I don't know about you. So thank you very much for supporting and asking questions. And I hope it's going to be some of the information might be useful for you. But and if you have any further question or you want to contact me, just send me an email. Thank you very much for the
Thank
attention.
you, Aizati.
Very much also.
Yeah. So yeah, please, Dr. Subhan.
And then I just thinking about the future, that maybe you have a time the next time to give a lecture also in our university, and then also possibility to see to find maybe a student for a student exchange between our institutions, between USM with Hasanuddin University. Also, if it is possible, also we can make a collaboration in research, maybe joint research or also a researcher exchange maybe in the future. I hope this is not the last to meet you.
Yes, doctor. Yeah, there's always
Thank
a
you very much.
possibility. There's always
It's a very
possibility for
interesting topic.
collaboration. Thank you. Thank you very much, doctor.
So
Thank
we
you
have
very much, Ochang.
Yeah, for the report, we have about 160 participants, and it's quite international. We have participants from Malaysia, maybe friends of Aizati, and I think there is someone from Thailand. So it's quite international webinar. So thank you everyone for attending our webinar. Thank you once again for Dr. Aizati for sharing your very useful knowledge for us and to enlighten us about this topic. And once again, we will meet for the next webinar, the fifth webinar, and stay tuned. We will inform the webinar through social media or WhatsApp. Once again, thank you very much. Thank you very much. And
Thank you. Bye-bye.
Bye bye.
Bye bye.